So my topic is binder face, a spectrum. We actually studied 8 such cases of binder's face which were referred to our institute as part of second opinion scan for suspected flat faces. Detailed anomaly scan was performed to evaluate if the flat face was there, and other organ systems were evaluated, and genetic testing including whole exome sequencing was offered to all the patients. So our objectives were to identify the fetuses with binder's phenotype, look for any other associated anomalies, and perform genetic testing to look for pathogenic mutations. So what is binder phenotype? It is more commonly referred to like as flat face. So what do we see in a flat face? We see increased nasofrontal angle, which is the angle between the frontal bone and the nasal bone, which usually the normal range is from 148 to 162. Greater than that, we call it an increased, and it is seen in binder's face. The nose is flat, the maxilla is hypoplastic. On axial scanning, we can see instead of the more rounded axial section of the maxilla, the anterior portion of the maxilla will be flat. The upper lip will be more convex and protruding. And if we do a 3D, we can see that the mid face is concave. Any associations, it can be isolated or can be associated with various types of chondrodysplasia punctata, metabolic abnormalities, or vitamin K deficiency. Even in aneuploidies like T21, we can find flat face. So of the 8 cases, the 4 such cases were isolated. 2 of them were associated with musculoskeletal anomalies, and 2 were associated with neurological abnormalities. So in case 1, in addition to flat face, we can see the stippled proximal epiphysis of femur. This is at 22 weeks. So at 22 weeks, we should not see any bone density proximal to the proximal end of femur. So this is stippling of the proximal epiphysis. In case 2, in addition to flat face, there was aqueductal stenosis. The supratentorial ventricles were dilated and cerebellum was hypoplastic. In case 3, which was primarily referred to us due to short long bones. In addition to short long bones, there was flat face and stippled proximal epiphysis of the long bones. In case 4, we have seen this case now. In addition to frontonasal encephalocele, there was flat face, and case 5 was one of the other 4 cases which was an isolated binder face. So in conclusion, we can see that the binder face can be isolated or associated with multisystem abnormalities. In the presence of other abnormalities, it is important to offer whole exome sequencing from amniotic fluid or product of conception, though many families fail to give it importance due to financial constraints. Case 1 underwent whole exome sequencing from the product of conception, but no mutation was found. In isolated binder faces, importance of genetic testing differs from case to case and is a subject of debate. We usually offer it to all patients, including we offer CMA to all the patients, but unfortunately many of them, some of them undergo testing, many of them fail to follow up or just terminate the pregnancy.